بسم الله الرحمن الرحيم. هو طبعا الحقيقة الواحد مش قادر يبقى في scientific event زي كده وما يفتكرش الدكتور حسين شعيشة ويتذكره دايما الحقيقة، خصوصا في المواضيع الصعبة اللي هو كان دايما بيخليها تبقى سهلة. So he's always in our hearts forever فعلا يعني. So I'd like to thank Professor Salah Naga and the organizing committee for inviting me to give this talk on transplanting a patient with thrombotic microangiopathy. And I'm going to start by this case because I hope by the end of this talk you will be able to answer these questions. This is a 23-year-old female who developed nausea, vomiting, jaundice, serum creatinine of 11.4 milligram per deciliter, hemoglobin 5 grams per deciliter, elevated LDH and platelet counts of 90,000 with schistocytosis, and a kidney biopsy revealed TMA. She did not respond to pulse steroids and plasmapheresis, and she was started on dialysis and remained dialysis dependent thereafter. This was in the year 2011. In 2012, she received a living unrelated donor kidney transplantation, and 3 months post-transplant, she developed a diarrheal illness and deteriorating kidney functions with biopsy showing recurrence of the original disease. She received high-dose pulse steroids and 4 sessions of plasmapheresis, and despite therapy, the disease continued to progress and the patient became hemodialysis dependent. In 2015, she was evaluated for a second kidney transplantation from her father. So what is the laboratory workup needed for the proper diagnosis? And what is your opinion concerning the salvage treatment that she received? And what is your advice for the second transplantation? And what is your plan of management for the second transplantation? So the agenda today will include the definition of TMA and the causes, and TMA in kidney transplantation, and approaching a patient with TMA in terms of diagnosis and management and donor perspective. So you all know that TMA is really triggered by an endothelial injury, and the histopathologic hallmark is the presence of the fibrin thombi in the glomerular capillaries and also maybe the arterioles, and this is going to result in narrowing of the lumen and ischemia will occur. And the fibrin thombi will cause consumption of platelets, and the passage of RBCs in the narrowed lumens will cause hemolysis, and you will see these schistocytes in the peripheral blood. And you expect to find thrombocytopenia, microangiopathic hemolytic anemia with all its manifestations, with increased bilirubin, LDH, and reduced haptoglobin. And depending on whether the kidney, of course, it can be limited to the kidney, but depending on whether the kidney or the brain lesions prevail, they used to differentiate in the past into HES and TTP. Then it became quite evident that the difference between them is, from the pathogenetic point of view, is different. In the TTP, the main reason is the deficiency or decreased activity of the Adams 13 protease enzymes, which functions to cleave the von Willebrand factor in normal conditions, whereas when it's absent, there's going to be accumulation of ultra-large von Willebrand factor that will attach more platelets and form platelet thrombi. And this can occur due to genetic mutations or more commonly, it occurs due to the presence of autoantibodies. Whereas in the atypical HES, the problem is in the the protein regulatory, complement regulatory proteins. We have the complement factor H and the complement factor I, which are fluid phase proteins, and we have the membrane cofactor protein, which is a membrane-bound protein. So these regulatory proteins, they function to stop the continuous activity of the alternate complement pathway. And if they are not present, there's going to be activation of the terminal complement component, and there's going to be endothelial injury. And again, this can be due to gene mutations, and the commonest of which are the complement factor H mutations, or again, more commonly, it can be due to the presence of antibodies against the complement factor H. And all these that I've mentioned, whether it is genetically determined or whether it's due to antibodies, are called primary HES. So if you exclude the Shiga toxin HES, which is the classic form of HES, and the thrombotic thrombocytopenic purpura, atypical HES is mainly the most thing that is going to be of concern to us. It's going to be the complement-mediated TMA, and I'm going to tell you why in a moment. It's true that we have many other secondary causes that can result in atypical HS, including non-Shiga toxin infectious agents, vaccination, cancer, malignant hypertension, pregnancy, autoimmune disease, and transplantation. But what is really of concern to us is the complement-mediated. Generally speaking, when you have microangiopathic hemolytic anemia, thrombocytopenia, and organ dysfunctions, you look at the if there is any apparent secondary cause, in which case you treat the cause. Whereas if you do not have an apparent cause, then you have to consider it as primary and treat as such with plasma exchange. And if you suspect atypical HS and you have the availability of eculizumab, then you may have to treat with eculizumab. So let's now concentrate in kidney transplantation. This is a very interesting paper, thrombotic marker angiopathy after renal transplantation, current insights in de novo and recurrent disease, and it is put by very, really you can see here the names of Professor Ahmed Halawa and Professor Mohsen Mkuti and others. So just like we mentioned, that it can be due to primary hereditary, due to a genetic defect, or primary acquired, and this is the primary forms, and it can be secondary due to Shiga toxin or other infections, or due to the many causes that we have mentioned, and still there is going to remain a group of patients with the diagnosis is unknown. So if you look at the incidence, the secondary is 90% of the cases, the primary acquired is 10%, and the primary hereditary is less than 3%. And in spite of that, the recurrence rate after transplantation is 80 to 100% in the primary hereditary and is 33 to 56% in the acquired, whereas in the secondary causes, the recurrence is negligible. So that's why this is the one which is of most concern to us. Not yet it is it recurs frequently, and the most common of which is complement factor H mutations. Together with complement factor I, they recur very frequently after transplantation. And look at the instance of the graft failure. So it is, though rare, it is a devastating thing to happen, and we have to try and stop this from happening. Whereas if you look at the membrane cofactor protein mutations, which is a membrane-bound protein, the recurrence is very low. This is present in the membrane. So when you put a new kidney with a normal membrane cofactor protein in its membrane, so it usually should not occur unless the donor has a membrane cofactor protein polymorphism that could influence the risk of the recurrence. So it's very important in these cases that you check for this in the donor. We have other problems, like we mentioned, the autoantibodies and C3 mutations, complement factor B mutations, and thrombomodulin mutations. Some of them are gain of function mutation, which is the more severe, and loss of function mutations. So what are the types when we are having a transplant patient? So the recurrent CMA occurs usually in 60% of the cases with atypical HS, but can occur with antiphospholipid syndrome associated with complement dysregulation, TTP, and autoimmune disease. The de novo is more common and occurs with drugs that we use commonly after transplantation, antibody-mediated rejection associated, the viruses, ischemia reperfusion injury, and transformed from the native kidney C3 glomerulonephritis. And look at this last one, unrecognized recurring TMA. So you can have a TMA that is not recognized, and that it needs a trigger that will make it show, and you will not be able to tell before the transplantation. This is the thing that makes it difficult, actually. So if you look at the causes of the de novo, usually you need more than one factor, like for instance, a patient receiving calcium urine inhibitors and he develops TMB, for instance. But then it was found that 29% of the cases, they have genetic mutations. So it's a form of a mix between the two. So if you look here, those with the genetic susceptibility, in 30% of the cases, there's going to be a trigger factor, whereas those with the environmental factors, again, in 30% of the cases, there's going to be a genetic factor. So it's a mix between the two. So what do we do for approaching a patient with thrombotic marker angiopathy? Of course, first thing, we have to diagnose. So the most definitive diagnosis, and when we do genetic screening, this is very important. So what if we don't have a genetic screening? So if this is not available, we'll have to depend on the clinical presentation. So if the patient has a previous history of TMA and there is no secondary cause apparent, then we may suspect this and we look for it. Or if the patient has a family history. Maybe even if the patient is coming with unknown cause for for renal failure, and this is a big group that we found in Egypt especially. So we need to have things clear, and what we can do, or the least that we can do, we have to measure the levels of complement factors, the C3, the C4, and the functional assays, and the complement regulators, complement factor H, complement factor I, complement factor B. But the problem is that test is unreliable because complement pathways can be activated in other disorders, and the levels can be normal. You can have normal levels, but you have the problem with the gene sequencing. So this is not the most definitive thing to do. And you can measure the membrane cofactor protein expression on the peripheral blood leukocytes, and you can screen for complement factor H antibodies. Genotyping is the most definitive, like we mentioned, but again, you have to know that in 30 to 50% of patients with atypical HAS have not identified genetic mutations. And of course, you go for screening for Adams 13 activity to exclude if you suspect TTP and antiphospholipid antibody. So it's very important that we stratify the risk for these patients because not all genetic mutations have the same magnitude on the graft survival. So this was established by the joint consensus of the American College of Medical Genetics and Association of Molecular Pathology in the year 2015. According to the guidelines, they divided the patients into 5 levels, starting from pathogenic to benign. And in 2017, the conclusions from the KDIGO guidelines, the controversy conferences, they divided the patients into 3 categories. The high-risk categories are those with previous early recurrence in a previous transplant, or who have pathogenic mutations, or gain-of-function mutations. So the recommendation was to use prophylactic eculizumab and start on the day of transplantation due to the potential for severe recurrence and limited recovery. And the moderate risk groups are those with no mutations identified, or isolated complement factor I mutations, or insignificant complement gene mutations, which are called a variant of uncertain significance. So here the prophylaxis will be eculizumab or plasma exchange. And those with isolated membrane cofactor protein mutations with persistently negative complement factor H autoantibodies, these are low-risk patients, and you don't need to give prophylaxis for this group of patients. Then in 2019, this was this patient that this paper that also showed that in those patients with variants of uncertain significance, further testing need to be done, and these require very specialized labs, like, for instance, testing for complement factor H regulatory proteins 1 to 5, and non-complement genetic screening for thrombomodulin and diacylglycerol kinase epsilon, and genomic rearrangement across the genes. And in 2020, there was this paper that added to the KDIGO guidelines further tests to be done, including the complement factor H related proteins rearrangements for the high risk, and for the moderate risk, homozygosity for complement factor H, H3 risk polymorphism, and for the low risk, it added the diacyl kinase epsilon pathogenic variants and thrombomodulin pathogenic variants, and those with no genetic findings were first included in the moderate risk. Now they are put in the low risk groups together with the secondary atypical HUS. So what do we do when we have such patients? Of course, we have to do genetic testing, as mentioned, but I know it's difficult, but it's expensive, but I have heard that there are coming in Egypt now and at a very affordable price. I hope this is going to start using it now. So first, general recommendations that we don't do nephrectomy for the native kidney. This is not indicated, and actually nephrectomy can be a trigger factor for the thrombotic microangiopathy. Bilateral nephrectomy is only indicated when you have refractory malignant hypertension or an ongoing activity despite treatment. You have to try to avoid ischemia, reperfusion, injury, and viral infections because, again, these are triggering factors. So try to avoid as much as possible. And we don't do calcineurin avoidance anymore, but it has been suggested by Ponticelli a long time ago that we can use anti-CD25 monoclonal antibodies together with MMF and steroids. Belatacept is one of the immunosuppressants that do not cause TMA. This is in contradistinction to all other immunosuppressive medications. So when to use eculizumab, and this is, of course, if we know the genetic mutations of all patients with atypical HS due to known pathogenic mutations in the complement proteins, except those with membrane cofactor protein mutations, and patients who have biopsy-proven diagnosis of TMA in the native kidneys, in whom a genetic variant has not been identified, but other etiologies of TMA have been excluded. So eculizumab needs to be given prophylactically. You can also use plasma exchange immunosuppressive with steroids and or rituximab when you have anti-complement factor H autoantibodies. You can use intensive plasma exchange due to mutations affecting plasma complement proteins when not complement, when you don't have the eculizumab, but when you still don't have it and you have a complement factor H, you have to go for liver kidney transplantation. And you know, eculizumab is anti-complement 5, and it's very effective, but of course, the duration of therapy is questionable. In patients with significant mutations, pathogenic mutations, it will be given indefinitely. And again, and the cost is prohibitive. It could be up to more than $700,000 each year, and to be given, probably it's much more now, and to be given indefinitely, this is very prohibiting actually. Now, this is a study on the 10-year outcome of eculizumab in kidney transplant recipients. It's a single center study from Johns Hopkins University. And this is what's interesting about that, it was followed up for 10 years. So in the group who did not receive eculizumab, which is in blue line, by 10 years, only 3 patients had functioning kidneys, whereas in the group who received eculizumab, 9 out of 10 patients had functioning kidneys, and the last patient had a rejection, which was not associated with TMA. So again, this is in trial to find out, and this study in 2021, and trial to find a way out of this very expensive drug. Bortezomib has been suggested to be used, but we still don't have enough data to recommend that. Or to use eculizumab upon recurrence. So you don't keep on giving eculizumab, but when there occurs TMA, then it can be given as a rescue therapy. This is another study, again, in trying to avoid eculizumab because of the price. It was done in 12 females and 5 male patients that were really had lost their previous transplants, 5 of them, and 16 carried a pathogenic or lightly pathogenic variant. And those patients were not given eculizumab, but they used living kidney donor in spite of the fact that this is not recommended, but they used the living kidney donor to get away from the cadaveric and the possibility of delayed graft function, and that could be a trigger to the occurrence of TMA. And they had basiliximab prophylaxis, and they had low-dose tacrolimus. They kept the tacrolimus at a low dose with a high-dose MMF, and they received prednisone, ACE inhibitors, and statins, good control of the blood pressure and the lipids. And at a median of 25 months, all patients had stable graft functions with a median serum creatinine of 1.2 milligram per deciliter. Of course, this is not a long enough period, but this is one of the things that has been tried. And only 1 patient developed recurrent TMA, and this patient was salvaged by eculizumab. And we have other studies indicating that even in cadaveric transplantations, there have been successful transplantation without eculizumab, but again, the follow-up was not long enough. So about the donation issues, I'd like to mention, what about the living donation in atypical HES? Living-related donor renal transplantation is not recommended in patients with atypical HES associated with mutations for complement factor HI, C3, complement factor B, given the unacceptable risk of disease recurrence. However, you can take this on base to base, according to each patient alone. So if you have a patient that you know his exact mutations, and you also do the same thing for the donor, and you make sure that the donor does not have the same mutations, you can accept that when living-related donation is the only possible option, complete genotyping of the donor should be performed to identify the unsuspected mutation carriers. In patients with mutations in the membrane growth factor protein, we should ensure that the donor does not share the same membrane growth factor protein mutation. And again, we mentioned nephrectomy may trigger TMA in the genetically susceptible donor. And it is recommended that patients who lost their graft because of TMA recurrence should not receive a second transplant, at least not from a living donor. Now we go back to our case. So what is the laboratory workup needed for the proper diagnosis in this second transplant? Of course, I think we mentioned that all, including the gene study, which is very important. And what is your opinion concerning the salvage treatment that she received? She received 4 sessions of plasmapheresis in the previous transplant. This is not enough to use, of course, and there is a recommendation for how to use the plasma exchange and when to stop it. بس هو مفيش وقت الكلام في ده دلوقتي. But of course, again, if we have ichilizumab, it is very important. Well, the problem is that we don't know if sometimes the patient has a TMA because it only appears with a trigger. And the trigger in children is usually infection. In adults, it's usually pregnancy. And those patients who develop acute kidney injury or TMA following pregnancy, this is a very highly suspicious and should be considered a typical HS and ichilizumab to be given if available or affordable. What is your advice for the second transplantation? It's not recommended to you to have her father for a donor, so it's better to look for another cadaveric transplantation. And what is your plan of management for the second transplant? I think we covered that all. Prophylaxis has to be given before, whether it's going to be ichilizumab or it's going to be plasma exchange and otherwise. So in conclusion, Mr. Chairman, primary atypical HAS has a high incidence of recurrence and poor prognosis. Identification of the defect underlying atypical HAS is instrumental to make informed decisions regarding listing for transplantation based on the risk recurrence. Diagnosis is not easy because it's a comorbid factors that we can have more than one factor together, and because of the unavailability of the genetic studies, hopefully to be available in the future. And again, even the genetic studies sometimes is not conclusive, and we still have a group of patients we cannot identify any mutant forms. Ichilizumab is a drug of choice for prophylaxis and treatment, but its price is prohibiting. And plasma exchange is a second option, plasma steroids and or rituximab for the presence of autoantibodies. And there is still a dilemma of secondary causes triggering TMA in a patient on a genetic background. And thank you very much. And again, I end by saying the more you know that you don't know. Thank you very much.